Hello and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain, here with my brother and co-host, Rohit Gosain. So far, for treatment algorithms, we've covered triple-negative breast cancer with Dr. Virginia Kaklamani and HER2-positive breast cancer with Dr. Sarah Simmons. Today, we're going to continue with the breast cancer series and dive into hormone receptor-positive breast cancer. And for this, we have Dr. Kevin Kalinsky, a breast medical oncologist and director of breast cancer program at the Winship Cancer Institute of Emory University. Kevin, thank you so much for joining us.
Thanks for having. I'm excited to be here. I look forward to that conversation.
Well, Kevin, welcome. To say there's a lot happening in this space would be an understatement. And as a community oncologist, to keep up with everything is very much an overwhelming process. Well, just in hormone receptor positive space, we've seen 2 new approvals and an update of overall survival with Inavolisib in metastatic settings. Sticking to early stage before we jump into the metastatic space, Kevin, can you please start us off with how are you using OncotypeDX to dictate your treatment in premenopausal versus postmenopausal women, and how does this change if the patient is node positive?
Yeah, I think what you have demonstrated here really is the approach. For those patients, we base this upon menopausal status, and we have data from Responder that those patients who are node positive as well, that have 1 to 3 nodes involved, if the recurrence score is less than or equal to 25, that we can think about safely foregoing chemotherapy. And for our patients who are premenopausal, who are node positive, we have this conversation about chemotherapy. That is a common question that comes up. Is there still a role for checking oncotype in patients who are premenopausal? And I think it's informative and prognostic, and I do it with patients. And of course, we don't fully know whether the benefit that we're seeing is due to this ovarian suppressive effect or not. Why we're doing the OFSET trial, which is randomly assigning patients to do ovarian suppression and endocrine therapy with or without chemotherapy to definitively answer that question.
And I actually have a patient enrolled in OFSET trial because we don't know the right answer here. We believe that ovarian function suppression in that early subset might be equally good, but we're eagerly waiting on the data. Kevin, is there any utility in ordering this recurrence score even on early biopsy to expedite the process, or waiting on full specimen post-surgery is the only way to do this right? Because we were doing some of this during the peak of COVID.
Yeah. In Responder, for instance, it didn't matter where you had the biopsy from, right? It could have been either the core, could have been the surgical resection tissue. And so I actually had this come up in clinic this week for a patient who's waiting for her surgery. She really wants to have the test. I said, let's go ahead and order it. But if you end up having 4 lymph nodes involved, we may cancel the test just to get the ball rolling. Sometimes I have done that.
And then when we're using these tools, we have other tools like MammaPrint. Should we rely on those other tools in any particular settings outside OncotypeDX?
Part of the ASCO guidelines are to use a genomic assay and stick with that genomic assay. This is a common question of, I had this, should I send the other test to help inform this? And really, I try to stick with that assay. I think for both of those tests, it's important to keep in mind that it is not just the score. It's also the clinical features as well. So, in the US, we have RS-Clin, which incorporates clinical and pathologic features for node negative. As of January, the node positive is also available for 1 to 3 nodes involved. The way that the MINDAC study was conducted for those patients with MammaPrint, it was also the incorporation of clinical risk. And so I would say right now, both are reasonable options. I tend to use the recurrence score primarily because I really like the RS-Clin tool. I find that very informative to discuss and individualize with my patients. There are other studies looking at the role of MammaPrint as an integral marker. I think this will continue to play out, including the role of IO for hormone receptor positive disease. There's an NCI study looking at that. Assays.
And then as we're talking about adjuvant treatment, at SABCS 2024, we also saw data supporting that if your recurrence score is high, anthracyclines might play a role here. This is a good segue into locally advanced disease as well. Kevin, your treatment for locally advanced disease, and who really gets anthracyclines even in early or locally advanced?
Yeah, actually, I'm really glad you brought that question up. As at San Antonio, we saw data from the Taylor-Rex trial, which looked at patients who had a high recurrence score, meaning those that had recurrence score that was greater or equal to 30. What they saw was that those tumors that were greater than 2 centimeters seemed to benefit from an anthracycline. And again, we're talking node negative disease. It's one of the first data sets that I have seen where the question was, is this predictive of the type of chemo you would use? And so I think that is an interesting analysis, something I would discuss with patients. But the other thing to keep in mind is that the field has really changed since then. We have other drugs available, like we have CDK4-6 inhibitors. Ribociclib would be approved in this setting for patients who have T2 tumors with a high genomic assay. And so I think it's a conversation with the patient. I'm not so sure that it's a one-size-fits-all approach just because it was a prospective retrospective study. To answer your question, I do generally use an anthracycline, or at least discuss it for patients who have 4 or more lymph nodes involved. I'll also say, the data we've seen from the US Oncology and SVP studies have shown for those patients with hormone receptor positive disease, that was a study that looked at anthracyclines versus just doing taxanes. And originally, when we saw those data, it seemed like the patients who had 4 or more positive nodes seemed to benefit from an anthracycline. But actually, with continued follow-up, that wasn't necessarily the case, but also understanding that that was an exploratory analysis. So long story short, patients with node positive disease, if they have 1 to 3 nodes involved, if they're a very young patient, meaning in their 30s, I might bring it up because about 60% of patients had anthracyclines. But in general, I've really started to move away from anthracyclines for patients, especially because we have CDK4/6 inhibitors.
Excellent.
Certainly, keeping patient shared decision making in mind. Kevin, the space of ovarian function suppression, there's quite a bit of confusion here as well, where what we rely for ovarian function suppression for premenopausal is goserelin, which is monthly, which is the approved agent. However, we've seen uptake of leuprolide because, again, one can administer 3 months or 6 months. What's your approach here, and how often do you check LH, FSH, and estradiol levels in these patients?
These are also big questions, patient specific. And so I think, also understanding that in some of the studies, like triptorelin was also, GnRH analog that was used. And so to me, my common approach is to use it monthly for the first 6 months, make sure that there's no breakthrough bleeding and that patients are in fact clinically postmenopausal. And then I might go to every 3-month dosing after that. That's generally what I do. And then the question about checking hormone levels. There are some labs like Mayo that look at ultra-sensitive estradiol levels. I have some colleagues that send it to there to check. I find checking estradiol, FSH, LH really hard to evaluate as someone's getting a GnRH analog. And when I've done this, I just feel like those labs are all over the place. When I have a conversation with a patient about starting a GnRH analog, I mentioned to them that sometimes it's hard to really know when you're naturally going into a postmenopausal state. And sometimes we have to commit to continuing that while you're on your endocrine therapy. And sometimes I've continued to check those labs, but again, I find them to be often unreliable and it comes back in a perimenopausal range.
Right. Kevin, in adjuvant settings, along with endocrine therapy, we now have the option of ribociclib, which is a wider approval, abemaciclib, and of course, PARP inhibitor olaparib. Any clinical pearls around these agents, and in a patient with BRCA-positive disease who would qualify for PARP inhibitors, and your approach here?
Yeah. For those patients who are germline BRCA mutants, the PARP inhibitor data, we have overall survival data from the Olympus. We saw those data at San Antonio. I start with a PARP inhibitor with their endocrine therapy. I have patients in my practice that are super high risk. I have a young patient who has many nodes involved. I might do endocrine therapy and a PARP inhibitor and then give a CDK4/6 inhibitor after that, not together, because that would be hard to tolerate and toxic. It's nice that we have 2 approved agents. As you mentioned, abemaciclib is for quote unquote high risk patients, node positive patients, and the ribociclib approval is for intermediate risk as well, which includes those patients who have negative but genomically or higher risk features. The big distinguishing feature is that abemaciclib is given for 2 years, ribociclib is given for 3. with additional follow-up, there seems like there's really benefit for both. I will say if a patient is eligible for both, let's say they have no positive disease, to me, I sometimes go to abemaciclib first, just because we have longer term data
Right.
and because it's 2 years. But if a patient's not able to tolerate it, then I have ribociclib in my back pocket.
I know we're moving through this quickly, but that is because there's so much to cover. Just a few things to reiterate, Rohit and Kevin, what you brought up. Abemaciclib got approved based off monarchy. Abema dosing is 150 milligrams twice a day for 2 years. Ribociclib is 400 milligrams, different than what we use in metastatic disease for days 1 to 21 and 7 days off. This is for 3 years. And again, these agents are approved because of invasive disease-free survival, whereas when it comes to olaparib based on Olympia, we indeed have overall survival.
Yeah.
Okay,
And
now,
if I may, I just add one additional point. Also, with the ribociclib, just remember you cannot give it with tamoxifen. So if you're
Yes.
giving it in the early stage
Yes,
setting, you
indeed.
have to, you're premenopausal patient, you have to do ovarian suppression and aromatase.
and when we're using Abema with tamoxifen, we also have to appreciate even further increased risk of VTE. So we just have to keep those few things in mind. Now on to metastatic breast cancer. Rohit, you had mentioned just in the last few months, we've seen quite a bit here. Kevin, can you walk us through our available treatment options? And importantly, how are you sequencing all this today in your clinic?
Yes. So as if the early stage setting wasn't active enough, you can see there's a lot going on in the metastatic setting. One thing that I have seen come up with my community oncology colleagues, in fact, yesterday I fielded 2 questions about this from 2 different community oncologists. The Inavolisib approval. So that is a new PI3K inhibitor. It is only approved right now in combination with palbo and fulvestrant. Okay, is approved as triplet therapy. We do not have, is not approved with ribo, and is not approved outside of this setting right now. We'll see other studies in the future answering different questions with inavolisib. Inavolisib is only, again, it's a PI3K inhibitor. These are for patients who have PIK3CA mutations. And this approval of the triplet is for a very specific population. This is for newly metastatic disease for patients who have tumors that progressed either on their endocrine therapy in the adjuvant setting or within 12 months of completing their adjuvant endocrine therapy. So those endocrine resistant patients. And we've seen press release that there is an overall survival benefit, which is meaningful. We have yet to see a survival benefit with any PI3K or AKT or mTOR inhibitor. This is the first time we're seeing an overall survival benefit, because the question has come up, triplet, that seems hard, that seems costly. We see an overall survival benefit now, but of course we'll see the data later on this year.
Kevin, there's quite a bit to discuss here. Before we move on to the topic of Inavo and other agents, there has been exciting debate about TDXD. What we have seen is based off of DB06 approval of TDXD in low and ultra low settings. Outside of clinical trials, would you use this in a patient with no HER2 expression at all? Especially when this test is so subjective to begin with, and now out, especially in community, asking pathologists to commit to no HER2 expression or ultra low HER2 will take some time.
Your question is like the heart of the matter. Like, how are we measuring HER2? Is it really that precise? It's an active drug. Like, should everybody get this drug? Right now, I'm at a center where the pathologists are quite engaged, and they'll say on their report, they don't say HER2 low or ultra low. They'll just say, 0, but with some membranous staining. Then that's the way of saying that it's, ultra low. I will say I've been using this for ER positive disease, for anybody who's ultra low, low, or HER2 positive. I haven't used it for HER2 0, though we also know that the more biopsies that you do, you may find something at some point that's going to show either a low finding. The one caveat to that is if I have a patient with triple negative disease and that HER2 is 0 and I'm running out of options, I have tried to get it in that setting.
What was the response rate there in your clinical anecdotal experience?
Low.
Okay, so coming back to hormone receptor positive, Inavolisib for this high-risk group, and then of course what we have been using CDK4-6 inhibitors with endocrine therapy if they don't fall into the Inavo group, and then thereafter looking for these actionable mutations, ESR1, PIK3 if you've not used it, AKT, PTEN, of course also the germline BRCA mutation. So looking out for these NGS actionable mutations, very important. What next? TDXD, likely anyone who fits into that bucket, keeping your ILD, nausea, alopecia in mind. Then, Kevin, this gets even more complicated. We have chemotherapy, sacituzumab, Dato-DXd recently got approved. Should there be a little break from ADC to ADC? Kevin, how are you sequencing these options in endocrine-resistant disease?
Right. A few thoughts in like no order of importance. All right. First of all, we do have data that for those patients who have germline BRCA mutations, they may not respond to endocrine therapy and CDK4/6 inhibitors for quite the same duration. So it's just one thing to be mindful of. Also, I find capivasertib to be much easier to tolerate than alpelisib. So I think that, we really started to favor that. And of course, the dosing is, 4 days on, 3 days off, and it's given twice a day when it's on. The other thing just to know as like a clinical pearl is that if you're checking circulating tumor DNA, it may be harder to find PTEN alterations. And so it is one thing to think about if you have a patient who doesn't have a PIK3CA mutation or AKT1 mutation, you may want to look in the tumor also just to make sure that it's not a patient that may benefit. All right. So let's say a patient doesn't have endocrine sensitive tumor anymore. For those patients who have a low volume of disease or low cadence of progression, capecitabine, still our friend, still appropriate for us to think about. Outside of that, I do agree. TDXD is a very good option. We've seen this compared to standard chemotherapy. The problem is, and you've already kind of alluded to this, is that second ADC is never as good as the first ADC for the most part. Like there's some data in these series that maybe, but we really don't know who those patients are. So the first one's generally better, and the payloads are the same mechanism of action. And so I do think it's reasonable to do after TDXD, either Dato-DXD or SASI, like either are options. We don't see that giving any chemo in between is any better than going directly one after the other, though those are just institutional data. And then the other question that has already come up from community oncologists is, would you do like a TDXD to a SASI to a Dato? I don't think so. In the original phase 1, there was a small group of patients who had prior SASI that responded to Dato, but most did not. And to me, I would think more about what TROP2 am I going to think about utilizing. For those that haven't had experience with Dato, I just want to mention, just got approved, it's given once every 3 weeks as opposed to 2 weeks on, 1 week off with the SASI. With SASI, everybody loses your hair. Dato, not everybody. The rates of ILD are still low with Dato, but with Dato, stomatitis, right? It is important that you are using the Dex rinse, or if you have access to it, preventatively. They recommend that you eat ice chips as you are having an infusion. You're really not supposed to be wearing contacts during the infusion or actually during the time that you're on Dato, though the rates of ocular issues are low and it tends to be more just keratitis, just more inflammation. So that's how I'm contextualizing the ADCs right now.
Thanks so much for covering that. And at least for here in hormone receptor positive, TDXD first, and then sacituzumab or Dato-DXD. In triple negative is slightly opposite, especially how we've seen the results or the responsiveness. Well, again, thank you so much for going over these new approvals and, importantly, this complex topic of sequencing. Dr. Kalinsky, thank you so much for covering so much in such a short time. For our listeners, let us go over a quick recap.
We've covered a lot in a very short time.
Indeed.
In early stage, use of recurrence score still remains the standard of care to dictate who would benefit from adjuvant chemotherapy. At this time, we eagerly continue to await if ovarian suppression would be equally good in some of these selected patients with these ongoing trials, particularly OFSET trial. We also now have 2 CDK4-6 inhibitors. We had a chance to touch on abemaciclib and ribociclib, and they're approved based off invasive disease-free survival. Rohit, your thoughts on early, localized, and metastatic disease?
Rahul, testing for germline mutation is extremely important. Yes, we have abemaciclib and ribociclib, but we also have olaparib, and we have overall survival benefit with this in patients with BRCA mutation. In metastatic settings, we have seen multiple new agents. Inavolisib for a high-risk patient with PIK3CA mutation and overall survival benefit, but we have to keep side effect in mind for this drug. And if not Inavo, we have other options of PIK3CA mutation. We can now also target ESR1 mutation. And then, of course, TDXD for ultra low recently got approved along with Dato-DXd. These are exciting times to be practicing as a medical oncologist, and thankfully our patients are living longer because of these interventions. Thanks for joining us. Make sure to check out our other discussions, including ToxCheck, conference highlights, and FDA approvals. We are the Oncology Brothers.